we'd like to welcome Ismail El Hamamsy up to speak not about Ross, but about some of his other expertise, aortic valve repair, in this case, remodeling.
All right, thank you, Joe, and once again, congratulations to Morale for putting together this exceptional meeting, and thank you to Dr. David for showing us the way over the years. So what I'll be presenting on now is remodeling procedure for bicuspid and severe AI with a root aneurysm. And I'll just give a couple of slides before I show you a 7-minute video, so it's a long version of the video. And my first slide is, there's always this topic of remodeling versus reimplantation. And I think we're well past this debate of remodeling versus reimplantation, as entertaining as it is when the debate is. I think the main goal is to have a durable valve preservation, and it's all about principles. Whether you do a remodeling or whether you do a reimplantation, it's all about the principles of surgery. And the principles are, in my opinion, fourfold. One is cusp repair. You have to reestablish good motion and symmetry of the cusps and bicuspids. Commissural orientation is very important to keep in mind when planning the operation and when performing the operation. Annular reduction through an annuloplasty is a key component because it's a ubiquitous finding in patients with bicuspid AI. And finally, trying to restore sinuses of Valsalva is very important, both in terms of flow dynamics as well as in terms of reducing or optimizing the stresses on the leaflets during the opening and closing during the cardiac cycle. So I'll skip over the first 2 points because we've heard a lot about cusp repair and commissural orientation. I'll just focus on the last 2 and then show you the video. So when you're doing a remodeling procedure, you saw all the data from the original remodeling series, either without any annuloplasty or any addressing of the basal ring or with limited annuloplasty bands in the fibrous portion, etc. Really, the dilatation in bicuspids, as we've learned from Jibrin, is at the expense of the muscular portion. So putting a little band in the fibrous portion does not do the trick. It's as if you're doing a mitral repair and you're putting an anterior band and leaving the whole posterior annulus behind. So you really have to have a circumferential annuloplasty. There are 2 ways that have been well described that I think each has its own merits. The external ring annuloplasty, in my opinion, is the most robust way of treating the annular dilatation. I call it a mini David procedure. It's exactly as if you're doing a reimplantation, except instead of having the long tube, you only have about 3 or 4 rings. The sutural annuloplasty was described in the late 50s, in the very early days of heart surgery, and was repopularized by Jochen Schaefer's recently. It helps. I use it as an adjunct when there is very severe annular dilatation along with the ring annuloplasty. And the sinuses of Valsalva cannot be overlooked. I know we're all talking about cylindrical and just a straight tube, and so far the data is very, very good. But there's a reason we were all created with sinuses of Valsalva. Otherwise, nature or God would have just created the aorta straight from the outset, as opposed to having these sinuses. They're important for coronary flow reserve, particularly during the systolic phase of the cardiac cycle. And they're also important for reducing the stresses on the leaflets during the opening and closing dynamics. And that's been clearly demonstrated through various studies looking at the stress distribution on the leaflets during the cardiac cycle. So there have been different ways and techniques that were proposed to try to restore sinuses of Valsalva, whether one is doing a reimplantation. The Valsalva graft was discussed, and whether yes or no. The David 5 procedure, as proposed by the Stanford group, like the Toronto group does, using a large graft and then plicating. My preferred approach is to do a remodeling procedure, which I think is the most physiological root reconstruction one can achieve, and add to it the annuloplasty ring, which then really addresses the one limitation of the remodeling procedure. And the reason I like this procedure is this is a patient who's 8 years after his root remodeling with annuloplasty. You look at the MRI, you really couldn't tell that this root was ever replaced. The leaflet motion is great. There's no flapping, and you do have 3 proper sinuses of Valsalva. So this is the case I'll show you. This is a 43-year-old patient with severe AI. He's got a right-left bicuspid aortic valve, a type B with commissures at 150 degrees. So really just the typical bicuspid aortic valve. The LV is dilated, the F is okay. The annulus is quite dilated at 34 millimeters, so that's one that we'll address in a rather aggressive way. And the sinuses are moderately dilated. This is the echo, the typical eccentric jet of aortic regurgitation directed towards the anterior leaflet, suggesting prolapse of that fused cusp. And the two findings, just like with the mitral regurgitation, is prolapse of the fused cusp and annular dilatation. You cannot ignore either of the two. You always have to address both when repairing or preserving valves. And this is the short axis view that we pay attention to, it, particularly in terms of looking at the commissural orientation, but also to look at on the right side of the screen, try to look at the color crossing the coaptation plane of the valve. And sometimes it gives you some indication whether the AI is at the expense of the right part of the fused cusp or the left part of the fused cusp, or all along the whole coaptation line. That can also be a little bit helpful in planning the operation. So this is how we do it. After transecting the aorta, we then examine the valve to make sure that it is suitable for preservation. So first we just look at the appearance. Is it pliable? No fenestrations, no retraction, no calcification. We measure the geometric heights. We measure the baseline effective height of the reference cusp, the non-coronary cusp in this case. And then we just play with the valve a little bit. Even if you're going to replace the valve, do take the 10 minutes to do so. And the first step I always do is just put the plication suture in the middle of the fused cusp and see how the valve will move, just to give me some sense of whether it's preservable or not. This valve was clearly a preservable valve. So we're going to mobilize the root before we do any leaflet work. This is the left and then the right coronary, as you see here, getting mobilized. I like to cut them in rectangular shapes. This way there's really no risk of torsion at the time of reimplantation. And then we do the deep dissection around the aortic root, like Jen showed very nicely. As we learned from Jabrine over the years, this deep dissection can really be extended quite aggressively to reach down to the level of the basal ring. And it really is key to get down to the level of the basal ring, whether you're doing a reimplantation or remodeling with a ring. And you see you keep cutting these fibers there, and you push with the scissors to roll out that muscle. And as Laurent said, if you get into the RV, which happens in my cases quite regularly, you just add a 4-0 stitch, and that's the end of the story. It's really not a big deal. Fill the ventricle. Even if you don't think you hit it, just fill the ventricle to be sure. And then the deep dissection against the non-coronary sinus is pretty simple. Then you resect the sinuses of Valsalva, leaving about 3 millimeters attached to the hinge points of the leaflets. When you cut, you really want to cut straight. Don't create sharp teeth as you're cutting, because that really is your hemostasis when you're doing a remodeling procedure. So if you're doing a reimplantation, you can be a little sloppy with that cut. If you're doing a remodeling, you really have to have it straight so that the sutures can then sit very nicely. Here we're shaving the free edge. You don't want to overshave the free edge of that fused cusp, because that is where those central plication sutures will be sitting, and it's nice to have a bit of fibrous component. This patient, as I mentioned, originally had a very large aortic annulus, and so I use a double annuloplasty technique in these cases. I see no downside to doing so. So I start off with the suture annuloplasty. This is a CV0 Gore-Tex suture. It's a big needle, and you put it at the level of the basal ring all the way around, and you tie it. We will eventually tie it at the nadir of the non-coronary sinus, and then before doing so, I'll get the annuloplasty sutures across. I usually use 6, but in bicuspid valves, we'll typically use 7 sutures at the level of the basal ring. They're mattress sutures using two-plegited ethibond, going from inside the aortic root to the outside of the aortic root. And here, at the level of the conduction tissue, as long as you get the sutures across the white stuff, just don't go through the muscle, you will not be catching any conduction tissue. There is no conduction tissue in the white portion of the annulus. It's basically the membranous septum. This is a 23 Hagar dilator. We tie the suture annuloplasty around it, and then the ring annuloplasty will be done at the very end of the case. So before doing the remodeling, we do the leaflet work, and it's actually pretty simple when you're doing a bicuspid valve preservation. All you're really doing, if you're going to position the commissures at 180 degrees, which is the position we're going to use here to create a type 0 bicuspid, is to equalize the lengths of the free margins of the leaflet. So you use the non-coronary cusp as your reference, and you just want to equalize those two lengths. So you remodel the free edge of the fused cusp by putting iterative 5-0 proline sutures in the middle of the leaflet, never towards the commissures because that's the area of highest stress. So stay in the middle of the leaflet because that's the non-load bearing part of the aortic valve. In diastole, this part really is not seeing any pressure. This patient had a bit of a diastasis here at the posterior commissure. I don't think the stitch really does much to change anything, but we just put it anyway. This is the raphe that we just cut. I don't know why I cut it so late in the operation. Normally that's the first thing I do when we open the root, but we just cut it at this point in the operation. And you see how now very symmetrical both these leaflets are in terms of free edge length. This is a 28 millimeter Dacron graft, and typically we'll use a 28 millimeter graft for most valve sparing operations, particularly when the root is not especially dilated. I count 15 rings, if that helps anyone here who wants to do remodeling. It's a starting point. I saw some of the videos, the remodeling starting from the commissure. As you'll see, the remodeling, the way we do it starts at the nadir of the cusp, and then we let the patient decide how high that split in the Dacron should go. So you keep extending it as high as the patient desires. And as Jennifer mentioned earlier with the reimplantation, the same concept. You don't want to cut V's, you want to cut U's so that you're actually allowing for sinuses of Valsalva to happen. If you cut a very sharp V, you're just going to end up with a very stiff sail. And then in the case of a right-left bicuspid, we'll start with the opposite sinus to the surgeon standing on the left side of the patient, so the fused cusp. You start at the nadir and the middle of the fused, of the Dacron graft here. And then a couple of things. One is every one of these stitches has to go at the hinge point, at that little yellow line, to exclude all remaining aortic wall tissue. And secondly, you try to incorporate the Dacron graft within the aortic wall. So we're purposefully pulling the sutures when we come out of the aortic wall so that the Dacron sits inside, and that really helps with hemostasis. And the last thing is, as you're going up towards the commissures, you move a little bit faster in the Dacron graft than in the aortic wall in order to create an accordion effect, because the more Dacron you have, the more of a sinus of Valsalva you'll create once the root pressurizes. And then once we're happy with the way the valve looked inside of the graft, you saw that we gave it a final inspection because we've now changed the commissural distance. So you have to make sure that you haven't induced any prolapse. Once we're happy with that, we're going to lower our annuloplasty ring into position, and then we're going to tie it. I don't tie it over a Hagar dilator because essentially the spacing through the LVOT is the same as the spacing I use across the ring, and therefore there's no real chance of cinching the annulus too small. And then the rest of the operation follows its normal course. You reimplant the left, you reimplant the right, and then you do the distal anastomosis. You can pressurize, you can give the cardioplegia, you can do all of these things, particularly in the remodeling. If you want to be sure that your hemostasis is favorable, it's not a bad idea to do so before closing the aorta, and that's the final look. And you'll see here on the echo, the valve opens quite nicely. There's no residual AI, and in short axis, you can also see the motion of the leaflet in systole and diastole. Thank you.